All right, so this is the belt. This should be around 2 inches below the armpit. So you technically can do um, a PulmoVista on a prone patient. You just have to put the strap backwards, basically. Give a little look at the amplitude of each breath. Patients on APRV. So you can tell, like with APRV, the lung is well splinted open, and there's almost barely any movement. And every time you're mechanically ventilating with positive pressure, you have to realize that that each time the chest moves, there's a possibility that we're irritating the lung or hurting the lung. So by reducing the amplitude with APRV, splinting it open you're moving the chest a lot less. And with that, by moving the chest less, you're stretching it out. You have a P high of 26. We're diffusing gases while the patient's up there, and when you expire, you have a more concentrated CO2 level depending on the diffusion capacity of the patient. So the patient is being ventilated on APRV, 6 cc's per kilogram. We're using the auto release, so we're only allowing 80% of the peak expiratory flow to be exhaled, and then we go back up to a P high. So we're using 80, and because of the auto release determining how long we descend and to what level based on the peak expiratory flow, you don't have a you don't have a T high, you don't have a T low set, and you don't have a P low set. It's all done with this. So this becomes actually the T low becomes a measurement and not a parameter, and that's all based on your auto release. You can do an expiratory pause. Okay, once the expiratory is paused. So even though the P low is set at 0, we're never going to 0. The P low is actually 9.4. So you do an expiratory pause, and then after you check, and that's the actual P low once you do an expiratory pause. Over here, this measurement, 3.5, that's the circuit pressure, and 0 the reason it's recommended to use 0 and to do air trapping with your T low is that you're not activating the PEEP valve. You want the least amount of resistance when it's releasing, so you can have the best gradient. If you're using a PEEP, you're going through a resistance, and that will decrease the volumes on expiration and cause CO2 retention. So this is the patient on APRV in the prone position. Therefore, the dorsal area, instead of being down here, everything's backwards. So dorsal, mid-dorsal, mid-ventral, and ventral. So you see 8 to 15 is normal. So normal distribution to the ventral area, to the mid-ventral area. And as we get to the dorsal area, things are, the mid-dorsal is actually pretty good. It's 30 to, so that's excellent. This is a little bit low over here. I'm going to print up the PulmoVista end inspiratory trends and end expiratory trends, but basically here on end inspiratory trend, if you look over here, I had various P high levels, and you can track it here with the axis of time. You can put your reference and you can check different P highs. The inspiratory and inspiratory trend. So you want to see what higher P high are we able to open, and after doing that, we realize that with pressures of 26, 30, up to 32, back to 26, 24, and then 22, we're seeing only around 22 a slight decrease here, a loss in the ventral region while he's prone. So after trying a recruitment maneuver, we finally decided to put it at 26. And this is the end expiratory trend to see your volume at the end of expiration. So we also did that initially. So we went over here. And we're looking for significant losses in impedance. Everything's staying positive pretty much. Minimal loss, but see, you're starting to get a little bit more loss over here once we went down to the 22, and you can see that it with the color. As we got down to 22, we were losing significantly with the impedance numbers, and we're seeing also a loss indicated by orange. Orange is loss and blue is gain. And don't forget, we're always comparing, so this is comparing to the reference. So compared to the reference of 28, we're down here to 22, significant loss. We know right away not to use that number. That's pretty much what we're doing. So now we're going to look at the tomography image prone. This is it now. We're going to flip the patient supine, and we're going to look at the difference, how the distribution of ventilation has changed. Okay, so now that we flipped the patient, this is the distribution of ventilation now that he is supine. We have a normal distribution of ventilation. We have very good distribution. 28% of the 375 is going to the dorsal region, so good aeration. We're in the gravity-dependent regions, but of course this is COVID, so his current saturation is 80% on 100. Sorry about that, I had to pause it. So the slope sometimes has a good influence on the tidal volume. So let's bring the slope down. Bring the slope down to 30 and see how it affects the tidal volume. 380 down to 320. 325. Let's bring the slope. Some people don't use any slope. 250. So the slope is important for good tidal volumes. So we're at 225. Then we turn to 22. So let's put it back to 1 second. And the tidal volumes will increase significantly. 350. 379. So always put a slope, helps with the tidal volume. So I'm going to put the reference over here, and we're going to trend to see what's happening. So compared to the reference, we're going to pay attention. So far this looks like there's less tidal volume to the bases. We have to keep an eye for de-recruitment, and we can use the end expiratory lung impedance, which is equals end expiratory lung volume. And we're going to trend to see if we're recruiting, de-recruiting, where is the recruitment, if there is happening, in which region. So here it appears that it's maintaining itself. There's no significant changes in the impedance numbers. Don't forget, if you want to know the tidal volume, change the impedance, numerical impedance to tidal volume. You just multiply that by your reference tidal volume, and then you're going to get the actual tidal volumes. But if you multiply 0.08 times 381, very minimal, a couple cc's of air difference. So we'll keep an eye on that and trend. Alright, so we have to flip back to prone position. Ever since we flipped him, the saturation's been pretty much 73 to 75. So he's currently on a prone. He's currently supine, and he was previously just recently prone. So prone, supine, and now we have to go back to prone. So even though the distribution of ventilation seems a lot better while he's supine, pretty decent, but with COVID there's endothelial damage, there is microembolies, so the aeration is usually not the problem, it's the perfusion through the lung. So there's a lot of endothelial damage, there's a lot of clotting happening at the capillary network close to the alveoli. So even if there's a better distribution, it doesn't necessarily mean that the patient's going to sat better with the COVIDs. This could possibly mean that He responds better when we flip him, and it has nothing to do with the aeration as much as just the blood flow. Once we flip him, the blood flow, because the gravity will pool over here more, and perhaps there's less clotting in the capillary network over in the ventral area compared to the dorsal.